You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
All right, we're coming up to the top of the hour, and so I want to get to maybe our last case here. 60-year-old man admitted to the hospital with dyspnea and abdominal bloating. He's been admitted 2 times this year for decompensated heart failure. There's no history of atherosclerotic cardiovascular disease, so no coronary disease. He's been taking furosemide, digoxin, warfarin, metoprolol. On exam, appears chronically ill. Blood pressure is low, 95/75. Heart rate is 95, irregular. CVP is to the mandible in the seated position. Carotid upstrokes are weak. Rales are present at the bases. Auscultation is notable for a holosystolic murmur over the precordium with an S3 gallop. Abdomen is distended. The liver is enlarged. Extremities are cool. The legs are edematous. The BNP, sky high, 1400. The ferritin is 89, transferrin sat 32, VUM of 60, creatinine of 2.5. ECG is AFib, rightward axis, narrow QRS, but a low amplitude. There's an echo that's done. EF is 50% with LVH. Pretty significant left ventricular hypertrophy there, 20 millimeters in the posterior wall, moderate MRTR, small effusion, severe biatrial enlargement. And so the question for us is, which of the following is the most likely diagnosis? You think this is cardiac amyloidosis? You think this is constrictive pericardial disease? Do you think this is HCM, hypertrophic cardiomyopathy? Is this HFpEF, like we've kind of talked about? Is this hemochromatosis? What do you guys think? All right, interesting, good. So this is one of the things that we talked about in the HFpEF talk, right? I mean, HFpEF is everywhere. And one of the things that we talked about was we want to exclude the non-cardiac and potentially cardiac mimics of HFpEF. And so when we talked about non-cardiac mimics of HFpEF, we talked about kidney disease. Jan talked about IgA nephropathy, right, nephrotic syndrome, proteinuria, and that can lead to congestion and volume overload. On the cardiac mimics of HFpEF, we talked about infiltrative cardiomyopathy. And so again, I know everyone's kind of primed now for HFpEF, getting BNPs, diagnosing patients, with HFpEF. And as you do that, and as you get echoes, also be vigilant and careful about, hey, did we really kind of make sure that there isn't infiltrative disease, there's no valvular disease, there isn't anything else that I have to be concerned about or worried about. And so very, very quickly, just in the last, couple minutes here, on amyloidosis, is this is also increasingly common. You will also find this and you'll see this. And obviously there's a lot of overlap between cardiac amyloidosis and HFpEF. You can almost think of this as kind of a subset of that. And there's lots of different proteins that can cause amyloidosis. But when we think about cardiac amyloidosis, right, where the heart is involved, we usually think about light chains in the setting of a plasma cell dyscrasia, multiple myeloma, Waldenstrom's, something like that, or transthyretin. That's prealbumin. And so we're certainly seeing a lot of ATTR amyloid in our practices now. And so that also is out there. You'll find it, you'll see it, you'll diagnose it. And the good thing for it is, some of the clues for cardiac amyloidosis, I think the third one down there, the discordance between QRS voltage on the EKG and wall thickness on imaging, right? This person had massive hypertrophy on their echo, and yet their EKG had low voltage, right? That's discordant information, right? That doesn't line up. If you see that, you're like, oh, maybe there's infiltration. That's why there's wall thickness on the echo, but on the EKG, there's actually low voltage because there's less muscle, because it's actually been replaced with deposition of protein, those amyloid fibrils. The other thing is carpal tunnel syndrome, and especially bilateral carpal tunnel. The likelihood of amyloid for that is really high. And so be alert for kind of carpal tunnel and amyloid, that association. I'm not going to go through, all of this in any kind of granularity, but the key test here for cardiac amyloid, especially if you're looking for transthyretin, for the TTR amyloid, is a pyrophosphate scan. You can also get a cardiac MRI, but the cardiac MRIs are notoriously difficult to get. Mm-hmm. And then we finally have treatments available. So the reason it matters that we make a diagnosis, and we have lots of treatments available, there's lots of different ways to kind of prevent that amyloid deposition, that protein deposition. The therapies are quite expensive. You can see on the far right-hand column there. But again, that's if you're making a diagnosis, there are therapies available. And then as a final thing to kind of close us out, maybe I'll even go back to where, Jan was saying, like, what an exciting time it is in terms of the things that we can do and where we've come in terms of managing, CKM and all of the other diagnoses that we've talked about today. But this is probably, the frontier of medicine, which is gene editing. So if there's a problem here you're making too much of a protein, you can use CRISPR-Cas9 gene editing to actually treat transthyretin amyloid. So CRISPR-Cas9 is already approved for sickle cell disease. It's being used in other clinical conditions. And so I wanted to include that as kind of, hey, like that's really the future. Think about the things that we can do. And so with that, as we come right to the top of the hour, we'll sort of close us out. I know we'll have some questions, hopefully for some back and forth, or some time for some questions and some back and forth too. But thank you guys.
Yes.
Thanks for watching. If you found this discussion valuable, be sure to subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.